Good afternoon, ladies and gentlemen. I'm John Min from South Korea, the chair of this session. Let me introduce the second speaker of this session, Professor Anna Wu from UCLA, Department of Molecular and Medical Pharmacology. And Dr. Wu is a pioneer researcher in the engineered monoclonal antibody for targeting and visualization of the tumor. That was started very early period of the molecular imaging research. So today, Dr. Wu will give us the talk about the probe development, antibodies, and immunoPET. Dr. Wu, please.
Thank you. And apologies to those who attended my talk yesterday. There will be a little bit of overlap, but today really my focus is on the class of antibodies as a class of molecular imaging probes. Okay, so why do we want to image with antibodies? I think the main reason is because we're able to obtain antibodies with exquisite specificity for pretty much any target of interest. You can get an ABCAM catalog. But in the old days when they used to print them, they were getting pretty thick. Now you can get pretty much any target, antibodies against any target of interest online. And I think not just availability, but certainly antibodies are workhorses in the laboratory. Every day, biological researchers are using or clinicians are using techniques such as flow cytometry or immunohistochemistry or Western blots or ELISAs to very specifically identify and quantitate protein and other types of targets. And I think importantly, we've seen over the last couple decades the success of antibodies as therapeutics. They are now blockbuster drugs in oncology. We have drugs such as trastuzumab or rituximab or bevacizumab that really are quite effective in oncology and really represent probably the most rapidly growing class of therapeutics in oncology. Here's an example then of immunohistochemistry staining a prostate cancer tumor for PSMA, prostate-specific membrane antigen. And the question is, can we also do the same type of very specific staining, as it were, but in vivo, using, for example, PET? So on the right actually is exactly that. It's an image of a patient, prostate cancer patient, where he was scanned with a humanized antibody that recognizes the same target, PSMA, but now labeled with zirconium-89 for whole body PET scanning. So how do we do this? That's really the point of today's talk. There are a lot of challenges in trying to adapt these large and complex biomolecules, shown here on the left, to positron emission tomography. They're really quite different from the small molecules that are really much more common as PET tracers. They're complex biological products. They have long circulating half-lives of days to weeks, typically. The starting materials that we work with are typically mouse monoclonal antibodies, and those proteins, when administered to patients, are highly immunogenic. Patients with normal immune systems, over 95% of them will develop human anti-mouse antibodies, and that precludes repeat administration, repeat imaging. And we are limited to cell surface targets in general because the antibodies, once internalized, will get degraded, processed, and become basically food for the cell. Although I always keep an open mind about what might be considered a surface antigen or not, because, for example, in diseases such as cancer, often there are proteins that we would assume would be intracellular that somehow do end up on the surface in malignancies. And there also are techniques that you can use, that certainly as research tools, to bring antibodies into the cell to look at intracellular targets, for example, using cell-penetrating peptides or nuclear localization signals. So there are a variety of approaches that people have employed to try to go farther into the cell. But in general, to the first approximation, we are looking at cell surface targets. And then whenever we're trying to do specific targeting, we always have to consider endogenous target expression, whether you're doing small molecules or large molecules. In oncology in particular, you're always looking for something that's differentially expressed in your tumors versus normal, or your disease state versus your normal tissue background. And that does become, I'll give you an example later. But I did want to show you, and actually John referred back to the early day, that we've actually been doing this for quite some time. And when we first approached the concept of trying to combine antibodies with PET, we had a classic challenge, which I describe as the irresistible force, because F-18 was the positron emitting radionuclide that was pretty much exclusively used when I first entered the field. We had the irresistible force of the F18 decay curve with its 109-minute half-life shown here. And then the flip side of that is we have this immovable object, which is an intact antibody, which just sits around for days. And so the scan I showed you originally, typically you're waiting 7 or 8 days after injection in order to do your scan, because you have to wait for all that blood pool activity to clear. And by that time, your F18 activity would be long gone. So fortunately, in the immunopet field, we've been addressing this on a couple of fronts. And one of the biggest advances, and it's been slow, but it's been building, and I won't say how long I've been in this field, but we now have the ability to access actually a fairly broad and growing spectrum of positron-emitting radionuclides with a variety of half-lives, and many of which have really opened the doors to imaging with biologicals. So for example, and I think I've highlighted the ones that we use in our lab, we've used fluorine-18, but we worked on copper-64 with a 13-hour half-life. And then in particular down here, there's been dramatic increase in availability of not just iodine-124, but zirconium-89 over the past several years, with 3.2 or 4.2 day half-lives, which are very well matched to the biological in vivo half-lives of antibodies and other biologics. Now, you do have to remember that we can pick and choose, but we don't always get all the properties we want. So other considerations to bear in mind are the fact that the gallium and fluorine-18 have very high positron yields, less so for these other positron-emitting radionuclides with only about 20% positron yields, for example. And the other places we pay penalties are we have to look at the energy of the positron. For example, gallium-68 and iodine-124 have very high energy positrons, so that does tend to degrade the quality of your image. But nonetheless, we do have a lot more choices than we did before. Okay, and then on the antibody side, what are we going to do to fix all those properties of antibodies? My group has approached it over the years by developing engineered antibody fragments. So here's your starting antibody, complex protein, slow blood clearance. Even after about 5 days, in these mouse models, you can still have 5 or 10% injected dose per gram in the circulation. You do get high uptakes because it is about exposure versus clearance. You have to have sufficient activity in the blood for sufficient time to perfuse the tissues of interest and allow an opportunity for strong binding and retention. But this is too long for imaging purposes to have to wait a week. So we start with engineered antibody fragments such as a single-chain variable fragment here, and then start building up larger intermediate size fragments. So we use a diabody, which is a dimer of single-chain antibody fragments. So it's really 2 of these, and it's a bivalent molecule. And then the next step up is to make a mini-body, which is a single-chain Fe fused to the CH3 domain from the intact antibody. That serves as a dimerization domain, but also it adds mass. So we have 80,000 versus 55,000 molecular weight. And that's a key point because proteins that are below about 60,000 molecular weight clear first pass through the kidney. You see that in the blood clearance curves here. They are gone by 3 to 4 hours after injection into mice, and that clearance is via the kidney, whereas the mini-body is above that threshold, so it clears a little bit slower, so you get a little bit longer persistence in the blood, which means you get a little bit higher uptake, but still it's gone by 24 hours. So, and the other key point about these engineered antibody fragments is that they lack the full FC region, the bottom part here, of an antibody. That's where all the effector functions reside. Complement binding, FC receptor interactions with monocytes, macrophages, other immune cells. And when you're developing an imaging agent, for a therapeutic agent, you may want to engage the patient's immune system, but for an imaging agent, especially if you're trying to take something to the FDA, you want something that's just biologically inert. So if you move to these fragments, you eliminate the issue of potential biological activity. So I think I've gone through pretty much all of these features, except to also mention that as long as you're engineering these antibodies, you can do things such as include novel amino acids for site-specific conjugation. So we and others use cysteine residues to provide thiols for thiol-specific conjugation so that you can have better control over where and how you are conjugating. But the important point is, by using these fragments, we maintain the affinity and specificity of the parent antibody, but we can achieve high contrast at much earlier times. And a picture's worth 1,000 words, so this is sort of a classic example of a target and protein that we've been working on in our lab for quite some time called prostate stem cell antigen, cell surface protein that's expressed in normal prostate, bladder, transitional epithelium of the bladder, and the lumen of the stomach at low levels, but it is upregulated in prostate cancer, bladder, and pancreatic cancer. And so this is a cognate set of parental antibody, minibody fragment, diabody fragment shown here. All have been labeled with iodine-124 and imaged in mice with subcutaneous tumors that overexpress PSCA. And you can see in all three cases very similar high contrast images of those subcutaneous xenografts, very low blood pool and other activity. But importantly, what you'll see is that we had to wait a week using the intact antibody to get that quality of image, whereas with these fragments, either next day or same day imaging becomes possible. And I think this is a particularly interesting format to be working with because it really is the only bivalent antibody-based format that you could conceivably label with fluorine-18 for same-day imaging, and I'll get back to that a little bit later. So I want to just give you a couple examples then of what you can do with these engineered antibody fragments. So this is an example using that PSCA minibody label with I-124 that I showed you previously. And it's really easy to find the subcutaneous xenografts, but this is a little more challenging model. Scott Knowles in the lab did an intratibial prostate cancer xenograft model, LAPC9 injected into one of the tibias of the mouse. We had a set of 6 mice, and they were imaged with sodium fluoride bone scans or with the tumor-specific anti-PSCA minibody. And the bone scans are challenging to interpret because these are young mice, they're growing, they're running around, so you see a lot of bone activity in general, and you're looking for asymmetry below the knees. And I think in mouse number 2 and maybe in mouse number 5, you can see a little tail of activity going down into the tibia in those mice with a fluoride bone scan where you're just looking at bone remodeling. Whereas those same mice now imaged with the tumor-specific agent, you can see very clearly where the yellow arrows are. There's a little bit of signal here, and in all 4 of these mice, you can see very small but very clear signal in the tibia that's on the left and nothing on the other side. These were quantitated, and you can clearly distinguish as early as 2 or 3 weeks after injecting these tumor cells. You can very clearly distinguish the presence of the tumor using the tumor-specific minibody. And here's a more therapy-related application. One thing that you can do is that you can, even if you have an antibody against a cell surface antigen, it can allow you to probe intracellular biology if you have a small molecule drug that acts in a way that will influence the cell surface expression of that protein. So this is an example because PSCA requires signaling through the androgen axis for maintenance. And so if you have just normal untreated tumors, you see very high signal by immunoPET. But if you treat these mice for 3 weeks with enzalutamide, which is an anti-androgen, what you see is downregulation of the cell surface PSCA, which you can detect by immunoPET. And when Scott went back and quantitated these very carefully, if you look pre-treatment and post-treatment, first the CT volumes are shown here on the top, and you really don't see a change at the 3-week time point between the volumes of the vehicle or treated pre-treatment versus following treatment. But after you do, and in this case, he actually went through the process of doing partial volume correction for the tumor sizes and then more rigorous quantitation, you can see post-treatment there's definitely a significant decrease in the level of PSCA expression. So you can't tell the difference by size, but you could certainly tell by activity level that you had indeed interfered with the androgen receptor signaling and downregulated. Okay, now one nice thing about antibodies is that they are large compared to the cargos we tend to put on them. And so you can actually put a variety of cargos onto a protein if you do it carefully without severely impacting the targeting properties. So here's an example where, well, first of all, fluorescent dye labeling. And this kind of, I think, to put it in perspective, it bypasses one of the challenges in developing small molecules that are radio-labeled, for example, with fluorine-18 or a radiometal or fluorescent dye, because when working with small molecules, changing one or a few atoms can have a dramatic impact on the binding and targeting properties or the biological distribution of those molecules, and we actually just saw some examples in the first talk, whereas antibodies are so large compared to the cargoes that we put on them that you actually can do quite a bit of modification and yet still retain excellent in vivo targeting and imaging. So here's an example of using fluorescent dye labeling of these engineered antibodies. Again, PSCA specific. This is a dye body that has a C-terminal cysteines, and we've used site-specific conjugation to put a fluorescent dye on. This was work that was done in collaboration with Rob Reiter, who's a urologist at UCLA, and his surgery fellow. So they implant these tumor cells intramuscularly, and it makes a very nice invasive tumor model. And what the surgical fellow did was, under white light, he removed as much of the tumor, as he could see, although in this case he actually deliberately left a region of tumor behind here. And then these mice had been injected with fluorescent Cy5 labeled cis dye body 6 hours prior to doing surgery. And so he did the surgery under white light, flipped on the fluorescence imaging, and here's the tumor he left behind, but here's an additional lesion that was not visible or not clearly visible under white light that clearly now shows up with the fluorescence. When he removes those additional lesions, he can, by H&E, did confirm that those indeed represented tumor involvement. So this is a way that you could do very target-specific intraoperative imaging. And we've now moved down to not just fluorescently labeled, but dual modality imaging. And this, for example, is the agent that one of my students has been working on, which is the PSCA minibody, labeled with a fluorescent dye and also a PET radionuclide. So it's dually labeled. And the idea would be if you had a patient who's a candidate for surgery, but you wanted to understand was there disease elsewhere, prior to committing to that surgery, you could inject this tracer systemically, do a PET scan, and determine whether it's just local disease or whether the disease had spread further. If it had not spread and you go ahead and do the surgery, you could then use, with the same tracer would still be there, and you could then use the fluorescent signal to guide the intraoperative imaging, use the intraoperative imaging to guide your surgical resection. So a student in the lab went Team Sci. Now she's taken the minibody, but similarly modified it to have a C-terminal cysteine residue, and she conjugated Cy5 to the C-terminus to get a fluorescent label, and then labeled the protein then in addition with iodine-124 to give the dual labeled probe. I will point out that you do have to be careful. It's not, it's not completely an inert, neutral process, because if you over-modify, even in this site-specific fashion, if you over-modify that protein with the Cy5 dye, you can push the biodistribution more towards the liver. So she found she had to really keep the conjugation ratio at about, not much higher than a 1-to-1 molar ratio of dye onto the protein. But regardless, you can see here the just some of the characterization by SDS Page and by size exclusion, showing you the co-migration of the dye with the protein. And this is what happens when she then injects tumors and images them first by PET and then by optical imaging. And so this first set of micro-PET images shows you that if you do make sure that you don't over-modify the protein, then the presence of the Cy5 dye on that minibody labeled with I-124 has no impact on the targeting and clearance and the localization and imaging ability of that dual-labeled agent. And then you can subsequently take the mice, and in this case we've peeled back the skin so you can visualize the PSCA positive tumor on the left shoulder versus the negative tumors on the right. And this allows you to then use the same agent in both the preoperative and the intraoperative setting. Okay. And then this is just to summarize that, and I think really one of the most important features about using antibodies as probes is that they do represent a platform that you can use approaches such as these to reformat any antibody of interest into smaller fragments, and you can pick and choose your PET radionuclide and your labeling method to generate a variety of immuno-PET reagents. We've really done this for a variety of tumor targets as shown here. And with the minibody fragments, we can do imaging 18 to 20 hours after injection. And with the dye bodies, as I mentioned earlier, we have the potential of doing same-day imaging. In fact, I think some of these, that HER2 image is a fluorine-18 image. Okay, and I did want to expand a little bit and tell you about what we've done in terms of imaging immune cell subsets, moving on beyond oncology, because we do have, first of all, the challenge of imaging in immune diseases and in immunotherapy, because FDG PET, which has been a mainstay of oncology imaging, is really not, well, it's specific, but it's not specific in that both tumor cells as well as activated immune cells do undergo this metabolic shift, and they do consume higher amounts of glucose. They do retain FDG signal. So in order to be able to distinguish between tumor cells and normal cells, and actually this was the question that was brought to me by Tony Rebus, was that in immunotherapy models, you'd see tumors get larger, you would see an increased FDG PET signal, and he said, is there any way we can distinguish the tumor cells from the immune cells? And I said, well, yes, there is. It took us a while to get it together, but we finally did. And so what I want to show you is 3 examples. One is CD8 cytotoxic T cells, one CD4 T cells, and then a third example using actually human CD20 specific agents to image B lymphocytes. Just to remind you, this is half of the hematopoietic lineage, the lymphoid side of the lineage, showing you the T cell lineage, the B cell lineages, and the natural killer cells. B cells, CD19, CD20 are hallmark cell surface markers. T cells, certainly CD3 on all of them, and then we get to these key subsets where the cytotoxic T cells express CD8, helper and regulatory T cells express CD4. But they're all very well characterized cell surface markers for differentiation, lineage, activation, et cetera. So they really present, to me, a gold mine of potential targets for antibody-based imaging. Okay, and so the first target we went after was CD8 on the cytotoxic T cells, and this just shows you an example of, here's the imaging agent itself, which is a cis diabody that's radiolabeled with zirconium-89, and this is we did blocking and depletion studies. First of all, here is a normal mouse, so you can see, because it's a cis diabody, it clears to the kidneys, but you can also see the spleen and a beautiful map of the lymph nodes of the normal mouse. And then in a blocking study, what you can see is that all of the signal has disappeared except for just the clearance to the kidney, which is the normal organ of clearance for these proteins. And then we moved on to a model of imaging stem cell reconstitution where the recipient mouse is irradiated, donor mouse provides bone marrow that gets transplanted in, and then we can image these mice over time, over a time course, 2, 4, and 8 weeks after injecting the bone marrow, and you can see the lymph nodes are filling in here from 2, 4, and 8 weeks, as well as you can see the outline of the spleen. The spleen sits on top of that kidney on the left, so sometimes it's a little hard to see, certainly in the MIP projections, but by 8 weeks it's clearly chock full of CD8 T cells. So we're watching the reconstitution of that compartment. And then finally, what we did was to image in cancer immunotherapy models with Tony Rebus's group, where we use a syngeneic CT26 colon cancer model. This is a very immunoresponsive model that many people have used over the years. And in this case, the mice were treated with an anti-CD137 41BB antibody, which is a systemic immune activator. When you treat those mice that are bearing these tumors, the tumors will slow down and then eventually regress by day 20. So what we did is we looked at day 15, both by micropet, but also if you take the tumors out at day 15 and stain them for those CD8 cytotoxic T cells, which are the actual active agent in this model, what you can see is that the mice that have been treated are chock full of CD8 T cells. And so can we see them in vivo in the mice non-invasively? The answer to that is yes. Here is the control mouse on the left, where you see, first of all, the kidney is the organ of clearance. You can see a lighter outline of the spleen sitting above the kidney. You can see this large tumor, which in the full projection looks like it has sort of a diffuse amount of activity in it. And when you go through the transaxial sections, what you see is the center of the tumor is cold. There is activity confined to the periphery, but basically there's just not a lot of activity in the tumor. Whereas the mouse that has been treated shows a completely different picture. The tumors are smaller and they are chock full. If you go through the cross sections, they are wall to wall involved with activity, and as you can see, the immunohistochemistry that's represented by the presence of the CD8 T cells. And interestingly, because this is a systemically acting antibody, you can see the entire mouse immune system has been activated. The spleen is very large, very red, so it's very high activity due to the increase in CD8 T cells, and all of the lymph nodes, and in particular, the ipsilateral draining lymph node are all enlarged and full of T cells. And then finally, there's a control here, which is a blocking study with excess cold CD8 minibody administered, and you can see that all of that signal in the spleen, lymph nodes, and tumor is due to specific binding of the CD8, specific cis-diabody immunopet probe. We can also image CD4 cells. This is an important helper T cell subset. A very similar story using a engineered diabody that's radiolabeled with zirconium-89. Here's the same stem cell transplantation model. You can see over time the increasing signal in the lymph nodes as we watch the repopulation, not of the CD8, but the CD4 T cell subset. So the images may look similar, but we're asking a different question. We're looking at a different subset of cells. And then this can also be applied in models beyond oncology. So we have started to look at autoimmune and other inflammatory models of disease. So this is an inflammatory bowel disease model where you treat the mice, normal mice, with dextran sulfate sodium in their drinking water for 5 days. And what happens is that by day 12, they develop colitis. And this is the hallmark of this disease, at least by histopathology, is massive infiltration of lymphocytes, in particular CD4 T cells, into these lesions. So we took mice, we have control mice, we have dextran sulfate sodium treated mice. So on the left is a control mouse, and as you've seen in the other previous slides, you see kidneys for the clearance, you see spleen, and a nice map of all the lymph nodes. And here in the DSS-treated mouse, the colitic mouse, what you can see is that the mesenteric lymph nodes are much larger and have a lot higher activity than in the control. And now we're seeing signal in the colon as well. And here on the sagittal view, it's really clear. There's the mesenteric lymph nodes, but we have CT contrast in the colon. So you can see in the normal mouse, the colon is cold. And in the colitic mice, there's a very high level of signal. And when we take those tissues out and image them ex vivo, it's very clear, very clearly confirms what we were seeing in vivo in the control mouse. Very low activity, a little bit in the cecum, but really the colons are cold. And in the DSS-treated mice, you can just see very, very strong signals, cecum, colon, and the mesenteric lymph nodes. We subsequently analyzed these tissues by flow cytometry and also by immunohistochemistry and confirm that that signal is indeed due to the presence, the infiltration of these high numbers of CD4 T cells. Now this next model I show, so moving on to the third model, which is CD20, for a number of reasons. One reason I show it is because this is now an example of going back to fluorine-18 labeled probes, because as I told you earlier, these diabodies do target and clear quickly enough that you can label them with fluorine-18 for same day, well, for imaging within just a few hours. Another reason I show this model is because it's a transgenic model of mice that express human CD20, because the antibody that we used is, it's actually a fragment derived from GA101, which I think is obinutuzumab. It is actually a therapeutic antibody that recognizes human CD20. And so what we wanted to do was we wanted to image the endogenous human CD20 signal in a transgenic mice, and then ask the question on top of that, can we image a CD20 expressing lymphoma in the context of the normal tissue, lymphoid tissue sink that you find in the spleen and the lymph nodes, because that would be mimicking more closely what you would see in a patient if you're trying to image, a B-cell lymphoma. You've still got the spleen and the lymph nodes, and that you have to also basically image through. So on the left is just the transgenic mouse itself, this collaboration with John Timmerman and his group. So this is a humanized mouse that expresses human CD20 in its B-cell compartment, actually at about a 7-fold lower level than the endogenous mouse CD20 signal, but nonetheless it's there. And here's the mouse just imaged with FDG PET, and as you expect, you see the Haldarian glands, you see the heart, you can see clearance through the bladder. And here's the mouse now imaged with the human CD20 specific cis-diabody labeled with fluorine-18. And now we see the spleen and the lymph nodes. So this is the B-cell compartment in that transgenic mouse. Next, we did a tumor model where if you inject the mice intravenously with, now this is a mouse syngeneic lymphoma, the A20 lymphoma, but it's also been transfected to express the human target. And if you inject these mice intravenously, those cells will seed the liver and form lots of micro, well, maybe not, micro nodules in the liver. So now if we image the tumor-bearing mice with FDG, you see, similar to the first panel I showed you, see heart, brain, and bladder, but you also see an increase of activity here in the liver region compared to the normal mouse. And then on the right, we now image instead using the CD20 specific cis diabody labeled with fluorine 18. And so here is a very hot liver. Those are those liver metastases, but in the context of the spleen and the lymph nodes of the normal lymphoid system. So this shows that, yes, these agents are able to pick up tumor, even though there is this endogenous background from the normal lymphoid tissues. So what about clinical development translation? This is work that's been done by Imaginab, where they've developed they've developed a number, but 2 of these gone into the clinic. What they have focused on is back to the minibody platform, and I think that choice was made because the minibodies do reach higher absolute levels of activity in our mouse models. So, the thought was that let's start with the fragment that would give you potentially more signal initially. So they're humanized minibodies conjugated with desferoxamine, labeled with zirconium-89 for immunopet. The first agent was developed recognizing PSMA, prostate-specific membrane antigen. That's gone into phase 1 studies in metastatic prostate cancer, and then also a phase 2 study at an earlier disease state, high-risk prostate cancer prior to surgery. And then the second agent, same format, but instead recognizing human CD8, and this is now in phase 1 in patients with metastatic solid tumors. So just quickly to summarize, this is published. This is work that was led by Anita Pandit-Taskar at Memorial Sloan Kettering, radio-labeled under the capable hands of Jason Lewis, who's hiding over there on the side. And they imaged patients with known metastatic disease, and these patients were, this is just a comparison in the same patient of a bone scan, FDG PET scan, and then using the tumor-specific PSMA targeting minibody scan. And these all recognize tumor based on different mechanisms, either bone remodeling or glycolysis. So bone scans will allow you to visualize bone but not soft tissue. FDG will show you all of the lesions, but prostate cancer, at least primary or early on, is not known to be, it's not as FDG avid as other tumors. And basically what they are finding is much higher ability to identify lesions using the tumor-specific agent. And then in this second, this phase 2 study, which was done, actually it was a head-to-head comparison with Prostascent, which is the FDA-approved intact mouse antibody that recognizes PSMA, labeled with indium-111 for SPECT. And now we've shifted to truly a much more customized imaging agent, which is humanized minibody labeled with zirconium-89 for PET. And importantly also, this is based on Neil Bander's antibody, which recognizes an extracellular domain of PSMA. And what was done is these are patients that I mentioned earlier that are candidates for therapy. They're newly diagnosed, they're candidates for therapy, but they have disease features that make them high risk for more distant metastases. And so it's a question of whether or not there actually is distant disease at the time of diagnosis. So this patient was a 65-year-old male with a high Gleason score, with a pretty high PSA, and that put him into a more high-risk category, but all the conventional imaging was negative, so he was a candidate for surgery. And prior to surgery, he was scanned using the zirconium-89 PSMA minibody, and what's interesting is that in otherwise normal-sized lymph nodes, activity was noted. So here in the blow-up, first of all, here in the overall scan, you can see liver and kidney uptake, and that hotspot is actually just clearance via the bowel. But in addition, you can see these lymph nodes that were normal-sized. So here's a primary prostate tumor here, very small lymph node there, and another lymph node there. So the surgeon, in many cases, would then go ahead and do an additional resection and remove some of those lymph nodes. And in this and other cases, the presence of tumor was confirmed by pathology. Okay. And then moving on to the second target, CD8, but now looking at human CD8 in patients. First of all, to confirm that the agent itself would image and detect human CD8 T cells. This is the agent here, humanized mini-body recognizing human CD8. And here is a humanized mouse model where if you take an immunocompromised mouse, severely immunocompromised NSG mouse, reconstituted with human peripheral blood mononuclear cells, what will happen is after a week, you engraft the humanized immune system into the mouse, but after 4 or 5 weeks, you get graft versus host disease as that human immune system recognizes the mouse as foreign. And what happens visually is shown here. First of all, in the 1-week image, you see the engraftment, you see signal in the spleen and the liver, which is an organ of hematopoiesis. So that liver signal is actually a combination of both clearance of the mini-body to the spleen, as well as the fact there are CD8 T cells in there. But if you wait a little bit longer, at 4 weeks, you see in addition, there's haze in the lungs. And the lung is one of the targets of GVHD in this model. And so when these mice were then, when the study was completed and we examined those tissues, you can see here are the CD8 T cells, human CD8 T cells in the spleen, but here they are also in the lung where they shouldn't be. And that's what's giving you graft versus host disease, but it is definitely detectable on those micro-PET scans. So finally, the clinical trial is underway. There's probably been about 5 or 6 patients that have been imaged, most of them at Memorial Sloan Kettering, led by Nita Pandit-Taskow, Jed Walchuk, Wolfgang Welber, and Mike Posto. And so this is one of the first patients that was imaged. She is a 37-year-old female with metastatic melanoma who's been on checkpoint inhibitor therapy for about 2 years. And what we see when we image with CD8 immunopet, first of all, it's important to note that there were no adverse events or side effects noted in any of the patients. And what we see here is rapid visualization of the normal lymphoid tissues in a human. So for the first time, we're seeing spleen, bone marrow, and lymph nodes based on directly imaging the CD8 T cells in those normal lymphoid tissues. And then what's even more of interest and potentially very exciting is that if you now look more closely here, this is from the FDG PET, and this is a small lesion in the muscles in the shoulder region in the patient by FDG. And then if you look at the CD8 immunopet, you can see in the same region you have co-localization of signal. So we believe that we're also able to image the CD8 T cells that are in the tumor of that patient that's undergoing immunotherapy. So I'd like to summarize here and hopefully show you that immunopet does provide a powerful, specific whole body approach for imaging cell surface target markers on tumor cells and immune cells. I will point out that I've talked a lot about engineered antibody fragments, but I do want to point out that because of the availability of zirconium-89 and I-124, many groups worldwide are now able to just take intact antibodies, approved, FDA-approved therapeutic antibodies, radio-label them with zirconium-89, and do immunopet studies. So that really has opened up this technology to a much broader number of laboratories and nuclear medicine facilities to start using antibodies on a more routine basis for cell surface imaging. We've just gone, a little bit farther to do these engineered antibody fragments, and that antibodies can be modified with a variety of imaging or therapeutic moieties, such as alpha or beta emitters, certainly, or toxins, or a variety of therapeutic cargoes, without major impacts on targeting and biodistribution, because they are such relatively large proteins compared to the cargoes that we typically are attaching to them. And in oncology, this allows us to assess a lot of interesting and informative questions in terms of tumor biology, target expression, whether your targeted therapies are getting where they're supposed to get, response to therapy, and I think especially exciting is the potential in immunology for profiling immune cell subsets, expansion, trafficking, activation, et cetera, and not just in oncology, but actually across potentially a much broader spectrum of diseases. So I will wrap up there and thank the members of my laboratory, past and present, our small animal imaging facility, my many collaborators at UCLA who in particular provided all these very interesting mouse models for us to do these studies in, and then of course our clinical collaborators at Memorial Sloan Kettering and colleagues at ImagineNab who developed and took the clinical imaging agents through the IND process and actually enabled the clinical studies. So thank you.
Thank you. Thank you so much for this nice talk.